Bismillahirrahmanirrahim. Now we'll talk about thoracic outlet syndrome. We left it last time here. So thoracic outlet syndrome is a compression of lower trunk of subclavian, lower trunks and subclavian vessels. So it looks something like Klumpke's palsy, that there is compression of the lower trunks. Along with that, there is subclavian vessel that is also being compressed. The what's that? The causes are cervical rib, which are shown in the arrows, and Pancoast tumor. Cervical ribs means supernumerary ribs which are above the first rib, and those are called cervical ribs. That are ribs in the neck. And then Pancoast tumor means we know that suppose there is a lung, so the apices of the lung are directed into the neck. Like this is the first rib, and these are the apices, so which are directed into the lung. If there is some tumor or the Pancoast tumor of this apical region, that Pancoast tumor can compress the lower trunks as well as the subclavian vessel. So that is called as thoracic outlet syndrome. The presentation will be same as that of Klumpke's palsy, and the resultant will be atrophy of the intrinsic hand muscles, ischemia, pain, and edema due to vascular compression. Okay, so there will be ischemia, pain, and edema due to the vascular compression. The subclavian vessel is going to supply the upper limb. So due to the compression of the upper limb blood supply, there will be ischemia, pain, and edema. Along with that, there will be atrophy of the intrinsic muscles of the hand. Moving to the winged scapula. So the winged scapula is the lesion of the long thoracic nerve. The long thoracic nerve that was coming from over here. This was the long thoracic nerve. Yep. And that was supplying the serratus anterior. That was supplying from that is the long route of origin and then long route of supply. So C5, 6, 7 routes are giving origin to long thoracic nerve. Coming back to this, so the long thoracic nerve is going to the axillary node. Pardon me. Lesion of the long thoracic nerve route C5 to C7 will lead to wings of heaven. Okay, I don't know what that means, but they are the wings of heaven, winged scapula. The cause is axillary node dissection after mastectomy and stab wounds. So during mastectomy, when we do the mastectomy for the breast carcinoma, CA breast, in that case we have to do the axillary lymphaectomy or axillary lymph node dissection, because the first node, the most common nodes for the metastasis of the breast cancer to go are the axillary nodes. So we have to dissect them, and during that dissection there are chances of damaging the long thoracic nerve, and also if there is a stab wound in that area, so that can also damage uh, the long thoracic nerve. So the nerve supply goes to serratus anterior, and inability to anchor the scapula to the thoracic cage cannot abduct the arm above horizontal position. We previously have seen that if this is the person and he is abducting the arm, so first 15 degrees are given by the supraspinatus muscle, then up to 110 or maybe say 90 degree, the abduction is mediated by the deltoid, and to go all the way up to 180 degrees, that thing is being mediated by the trapezius and the serratus anterior. There are two muscles that help in that motion, but if the serratus anterior is damaged, so in that case we cannot abduct our arm more than 90 degrees, and that condition is called as winging of the scapula. Then okay, so before moving further, I would like to show you a mnemonic of the dirty medicine over here. So it is a mnemonic to remember the site of damage of different nerves of the upper limb along with the manifestation which happens. So we'll see that video.
University is important, and you should be able to name some.
So it is like this is a mnemonic: Arm University, name some. So in Arm University, you are going to name some upper limb nerves. Remember like that. So Arm University and name some. This is a mnemonic. So now we'll see it. So in the A means axillary nerve, and the N means that neck fracture. So whenever there is fracture to the surgical neck, yeah. Whenever there is neck fracture to the surgical neck of the humerus, there will be damage to the axillary nerve. Remember this thing. So if I draw it here, that suppose here we have the humerus. Okay, here we have the humerus, and if there is damage to this area, there will be a radial nerve and then medial nerve, and then we have ulnar nerve. Basically, just give me a second. Medial nerve, then we have ulnar nerve, long thoracic. Okay, there we go. So here you can see that if there is damage to the surgical neck, we are supposed to damage the axillary nerve. So in this mnemonic, Arm University, the A is corresponding with the N. So if there is axillary nerve will be damaged when there is damage to the surgical neck of the humerus. Okay. Then we have R is for the radial nerve, and radial nerve is corresponding with the AM in this mnemonic. So it means a radial nerve, axilla or mid shaft fracture. So if there is damage inside the axilla, some trauma to the axilla is there. For example, the person who is using the crutches, we'll see that as well, or sagittal night palsy, or if there is mid shaft fracture. So in those situations, we are going to face the radial nerve damage. So if the damage is on the mid shaft, so there is radial nerve damage. Then moving forward, we'll talk about median nerve. So here you can see that if there is crutch palsy, so because crutches are pushing into the axilla, in that case, or the person is sleeping on the Saturday night drunkard on the chair like that, so these people also present with them. That the name, there's a name that is called Saturday night palsy. I don't know what the significance of that, but let's move on. I guess because on weekends people drink a lot and then they come to the doctor because of the radial nerve palsy, wrist drop and stuff like that. Okay, so then we have next is median nerve. So median nerve, the mnemonic for that is that's supracondylar fracture. So if there is supracondylar fracture, that can lead to, and supracondylar I guess on the medial side. So medial supracondylar fracture can lead to, here you can see the ulnar nerve. We're talking about ulnar nerve. Name some. Yeah, we're talking about ulnar nerve. So if there is fracture of the medial epicondylar or supracondylar fracture, no, that he what's that? Give me a second. When we're talking about median nerve, I'm sorry. So median nerve will be damaged if there is damage above the above the condyle, that is called a supracondylar fracture. Like the condylar region is over here, and if there is damage above that in the supracondylar region, our median nerve becomes at risk, and the median nerve can be damaged in this particular location. And then for the last nerve, that is the ulnar nerve. So if there is damage to OME, that is medial epicondyle fracture, or when the person falls on the outstretched hand. That is very important because they often give you this mnemonic that the person was, the elderly person was going and then he tumbled on something and then he fell on the floor on his outstretched hand. Due to the damage to the outstretched hand, the person can damage the medial epicondyle or the ulnar nerve. So here you can see that if the medial epicondyle is damaged, if the fracture of the medial epicondyle is there, then ulnar nerve will be damaged. If there is supracondylar damage, median nerve will be damaged. Mid shaft fracture can damage the radial nerve, and neck fracture, surgical neck fracture can damage the axillary nerve. So remember these things. Now let's move to the name of the lesions. So some of the lesions which are to be named are as follows. Yep. So axillary nerve. Just give me a second. Yep. So if the axillary nerve is damaged, we cannot abduct the arm. Why so? Because axillary nerve supply the deltoid muscle, and deltoid muscle is a big abductor of the arm. Secondly, if the radial nerve is damaged, so we have wrist rope. So wrist rope is with the R to make it memorable. Then median nerve C5 to T1, monkey hand or ape hand. That is a picture of ape hand. And then we have ulnar nerve damage that can lead to claw hand. So remember the names of these things. Like they can ask you anything about this. They can ask you the root values which are damaged, like for example it is C5 C6 and for radial C5 T1, median also C5 T1, and ulnar is C8 T1. They can ask you stuff like that because these things we have seen in the brachial plexus, but this would be a difficult question to ask. Most of the times they ask you that what is the name of the injury, what is the movement that has been lost, and which nerve is damaged. So these are the easy questions, but if they are up to something very big and they are going to ask you something very nasty, so they will be asking the root values and stuff like that. So remember these things, that axillary nerve damage will not allow you to abduct the arm, the radial nerve damage will cause wrist drop, the median nerve damage will cause ape hand or monkey hand, and ulnar nerve damage will lead to ulnar claw deformity. Now let's come back to the PDF. So we talked about different type of injuries to the brachial plexus. Now we are going to talk about upper extremity nerves one by one. So axillary nerve injury, axillary nerve C5 to C6, causes of injury: fractured surgical neck of the humerus. So what is the difference between surgical and anatomical neck? So suppose this is the humerus, it is head of the humerus, and then we have these two tuberosities. I'm just trying like that, and then we have the distal end, and here we can see. So this is the area, the dotted area which I'm drawing right now. This area, this is the anatomical head, that is anatomical neck. The constriction just distal to the head of the humerus is called as the anatomical neck. Just adjacent with the head, that thing is called as the anatomical neck. And then if we go past these tuberosities, so there is this thing, the narrow area after the greater and lesser tuberosities, that area where most of the fractures occur, that is called as the surgical neck. Because this is of clinical significance, this is not of anatomical significance, so we call it surgical neck, and anatomical neck is over here. Now let's come back to the point that if there is fracture to the surgical neck of humerus, we are supposed to damage the axillary nerve. Anterior dislocation of humerus, okay, Anterior dislocation of humerus most often occurs in the subcoracoid position. Okay, anterior dislocation due to blow or blow to an externally rotated abducted arm, for example, throwing a ball, flattening of the deltoid prominence, protrusion of the acromion, and anterior axillary fullness due to the humeral head movement into this location. So suppose that a person has externally rotated arm when he is throwing a ball or something. So throwing a football. I'm sorry. So when it's not the usual football, it is the football that is played in America. The brown ball, and when the people are throwing that. So in that case, the arm is abducted, and if somebody hit at that point, and the conditions are in favor of enough damage. So this will lead to anterior dislocation of humerus. So these are the two situations when we can damage the axillary nerve. First one is a surgical neck fracture, or there is anterior dislocation of humerus that can occur when there is blow to the externally rotated and abducted arm, that is throwing of the football, flattening of the deltoid prominence, which is protrusion of the acromion, okay, which will show the protrusion of the acromion, because deltoid prominence is being supplied by the axillary nerve. If axillary nerve is not supplying that, so there will be flattening of that prominence, and then we have anterior axillary fullness due to the humeral head movement into this location. So anterior axilla is the location where the anteriorly displaced humeral head will be. So we will feel the anterior axillary fullness. Presentation: there will be flattened deltoid because an innervation is lost. Loss of arm abduction at the shoulder more than 50 degree because deltoid innervation is lost, and deltoid was the main abductor. Loss of the sensation of the deltoid muscle and the lateral arm. Sensations are also being lost because the axillary nerve is responsible for the cutaneous innervation of this area. I guess there is a picture of that. There is no picture of that. That was not present even in the lateral atlas. So let's move on. So musculocutaneous nerve. Musculocutaneous nerve causes of injury: upper trunk compression. Presentation: loss of forearm flexion and supination, that is coracobrachialis, and loss of sensation over the lateral forearm. Lateral forearm, because the lateral cutaneous nerve of forearm is coming from the musculocutaneous nerve, I guess, if I'm not confusing myself. So just forget about that. So the presentation is loss of forearm flexion and supination, that is coming from the coracobrachialis, and the loss of sensation over the lateral forearm. Okay. Here you can see the lateral cord of brachial plexus that is giving rise to this musculocutaneous branch, and that musculocutaneous branch is moving through the coracobrachialis, and then supplying the brachialis and the bicep brachii. Then it is coming laterally as a lateral cutaneous nerve of the forearm. Okay, so this is the pathway. There was no pathway for the axillary nerve. Okay, so then axillary nerve is coming from the posterior cords, right? Here you can see the posterior cords are giving rise to axillary and the radial nerves. So what is the damage? So you can think about it, that if there is damage, so there will be loss of forearm flexion and supination, because both of these coracobrachialis and the bicep brachii are the big supinators and flexors of the forearm, and the loss of sensation of the lateral forearm will also be gone because lateral cutaneous nerve of forearm is gone now. Then what is radial nerve? Radial nerve originates from C5 to T1, also coming from the posterior trunk. Causes of injury: compression of the axilla, for example, due to the crutches, or sleeping with arm over the chair, that is known as Saturday night palsy. Humerus fracture mid shaft or supracondylar fracture. Okay, even supracondylar fracture. Supracondylar means above condyle. So it can be anywhere above condyles. So the damage is, suppose if it is not here and maybe somewhere above it, and the radial nerve was caught in that, so that can cause, the damage to the radial nerve. So, but main thing is that you must remember the mid shaft fracture, that is the big one and highlighted over here. Repetitive pronation and supination of the forearm, for example, due to the screwdriver use, that is called finger drop. So normally the radial nerve damage will cause wrist drop, but if there is repetitive pronation and supination of the forearm by repetitive screwdriver use, so I guess there will be finger drop or something like that. So repetitive pronation and supination, that can also damage this nerve. Repetitive pronation and supination. Okay. Then we have presentations: the tricep weakness, that is axillary injury. If the injury is inside the axilla, there will be tricep injury. Wrist drop, loss of elbow, wrist and finger extension, loss of sensation over the posterior arm, forearm and dorsal hand, and decreased grip strength, wrist extension necessary for the maximum action of flexors. So the thing that you must remember about radial nerve is that the radial nerve is the supply for the extensor compartment of our arm and forearm. So in the arm, it is going to supply the tricep muscle. In the forearm, it is going to supply the posterior compartment, which houses most of the extensor muscles. So remember that the radial nerve is a nerve for the extensor compartment of our upper limb. Secondly, Now they're telling that there will be tricep weakness if there is axillary injury, then wrist drop, loss of elbow, wrist, and finger extension. Extension will be lost. Then loss of sensation over the posterior arm, forearm, and dorsal hand, and then decreased grip strength. Wrist extension necessary for the maximal action of flexors. So this is a phenomena. Suppose that this is my arm, and then this is my hand in a flex position. I don't know how to draw my hand like this, and maybe. So if my hand is in the flex position, try to keep your hand in this position, in the flex position, and then try to clench your fist. It will be harder for you. It will be hard for you to clench the fist completely, and then try to extend your arm completely. Extend your hand. I'm sorry. We are doing the movement of the wrist. Do it on your own hand. So if it is flexed, so it will be hard for you to do the complete, grip of the hand. But if you extend your hand completely like this and then you grip your fist or then you make a fist, it will be very easy for you and it will be a strong grip or strong fist that will be formed. It is a phenomena that when you flex your hand, the muscles, that the tendons of these flexor muscle, the length of the tendon decreases because suppose this is the tendon and the length that was in the point of insertion, this is the point of insertion to the muscle that decreases. That is why the flexion becomes weak. But if you extend your hand, the distance of the length of the tendon increases, the length of the tendon increases, and the insertion side becomes more distant from the muscle. So the muscle strength increases, and that is why it is written that the wrist extension necessary, wrist extend wrist extension is necessary for the maximal action of the flexors. So if the radial muscle or the extensor strength is gone, resultantly we cannot have a very strong flexion of the wrist joint. Then here you can see in this picture it is on the lateral atlas. So here they are showing that the posterior aspect of the upper limb completely, arm, forearm, and even hand, that is being supplied by the radial nerve. And in this picture they have also shown that from the axillary nerve we get the superior lateral brachial cutaneous nerve that is supplying over the deltoid region. Then there was also a picture about musculocutaneous nerve over here. Musculocutaneous, yeah. Here you can see the musculocutaneous is supplying the lateral aspect of the forearm by the lateral antebrachial cutaneous nerve or the lateral cutaneous branch of the forearm. Here and here. Then moving forward to our picture, PDF, sorry. So here you can see that radial nerve. The radial nerve is coming from here. Okay, it can be damaged in the mid shaft. So it is the distal end of the humerus over here. It is coming from behind the forearm to the extensor compartment of the arm, behind the arm to the extensor compartment of the forearm. Here it is lateral epicondyle, then deep branch of the radial nerve, then supinator muscle is over there, superficial branch of the radial nerve, posterior trochleus nerve, and then we have superficial branch of the radial nerve. Okay, so you are not supposed to remember any of that. Then we have Uworld point that injury to the radial nerve during its passage through the supinator canal, okay, may occur due to the repetitive pronation and supination of the forearm. That's the point. That why is there damage due to supination and pronation? Because there is a muscle called a supinator. I guess it will be a better picture over there. About the radial nerve, radial. Yes, here we have the radial nerve. Radial nerve passes between the supinator muscle. Here we have the supinator muscle. Supinator. Supinator muscle. Okay, supinator triceps. Okay, I have to find it. But there is a thing that we call supinator canal, and there I just saw supinator muscle is over here. So here you can see that this is the supinator muscle, this one and this one, and the radial nerve is passing from between that. So if there is excessive contraction and relaxation of the supinator muscle for no reason, that we are just using the screwdriver, repetitive pronation and supination of the forearm, direct trauma or subluxation of the radius can be there. Okay, no. Listen. Injury to the radial nerve during its passage through the supinator canal may occur due to repetitive pronation of supination of the forearm or direct trauma or subluxation of the radius bone. So these are the two things that can happen. Patients typically have weakness during finger and thumb extension, that is called as finger drop, without wrist drop or sensory deficits. So remember this point, that if we have damage of the radius more proximally, like suppose in the axilla or in the mid shaft fractures of the humerus, then there will be wrist drop. But if there is repetitive pronation and supination, or the person is had some trauma and the radius came out of its insertion, came out of its annular ring, and now radius is dislocated, so that radial trauma to the radial nerve will lead to finger drop. Okay, then we have wrist flexion and extension. Major flexors, median ulnar nerve. Okay, median and the ulnar nerve are the major flexors. Flexor carpi radialis and flexor carpi ulnaris. This was something I was talking about. If you flex your wrist all the way here, so you cannot close your fist, right? Okay, and then if the major extensor of the radial nerve, Major extensor being supplied by the radial nerve, like extensor carpi radialis is longest, extensor carpi radialis brevis, and extensor carpi. That is, if you extend it, then you can clench your fist very strongly. So grip strength is decreased if the radial nerve is damaged. Moving forward to the median nerve, that is coming from C5 to T1 root value. Course. The median nerve courses between the humeral and the ulnar head of the pronator teres muscle. Where is pronator teres? Here we have the pronator teres. So between the ulnar, no, between the humeral. Okay, here we have the humeral end, and then here we have the ulnar head. Where's the ulnar head? No, no, no. Okay, so there are humerus over here, and the ulnar head is over here. So between the humeral and ulnar head, the median nerve is passing. It runs between the flexor digitorum superficialis and the flexor digitorum profundus muscle before crossing the wrist within the carpal tunnel. Okay, so this is the nerve that is present inside the carpal tunnel, and it is damaged during the carpal tunnel syndrome. Remember that point. And if you are a geek, so you can also remember that it is passing between the flexor digitorum superficialis and the profundus, and also between the two heads, the humeral and the ulnar head of the pronator teres. Causes of injury: supracondylar fracture of the humerus, proximal lesion, or the carpal tunnel syndrome, and wrist laceration, that is a distal lesion. So there are two type of lesions, and the palmar involvement is different in these two lesions. So supracondylar fracture of the humerus, proximal lesion, and the carpal tunnel syndrome, and the wrist laceration and the distal lesion. These are the type of lesions. Presentation: there will be ape hand or the monkey hand for the median nerve. Remember. Now here at wrist. Okay, so ape hand at wrist. If there is damage at wrist, there will be ape hand. Thumb adducted, cannot oppose or abduct the thumb, and there will be thenar atrophy. Pope's hand, also known as hand of benediction, asks the patient to make a fist. The thumb and the little fingers cannot flex. Metacarpal phalangeal joint is extended. So I guess this is the Pope hand, and this is the ape hand. So these are the two things. If there is damage at this position, so there will be ape hand. And I don't know when this happens, but this is the Pope's hand or hand of benediction. Loss of wrist flexion, flexion of the lateral fingers and thumb. Loss of wrist flexion and the flexion of lateral fingers and thumb. Opposition lumbricals of second and third digit is lost. Loss of sensation of the thenar eminence and the dorsal and palmar aspect of lateral 3.5 fingers with the proximal lesion. So here you can see in this picture. There's the radial nerve. Let's go to the median nerve, ulnar, and we have the median nerve over here. So median nerve supplies this much of your hand, the cutaneous innervation I'm talking about. So this cutaneous innervation is coming from the median nerve. Secondly, the point to ponder over here, that here you have the carpal tunnel is over here. Okay, so the tunnel you can see in this picture, this one I'm highlighting right now. This is the flexor retinaculum, and this flexor retinaculum is forming the roof of carpal tunnel. So the median nerve is passing below that, but there is only one branch that moves above that. That branch is this. What the branch? The palmar branch of the median nerve. So if the palmar motor supply and the cutaneous supply is intact, in that case we suspect that the damage is inside the carpal tunnel. But if the palmar supply is also lost, then there is some proximal lesion at the supracondylar fracture, something like that. Then coming back, so remember these two hands, hand of benediction and the ape hand. Now we have recurrent branch of the median nerve, the motor innervation of the thenar muscle, no sensory innervation. So the recurrent branch of the median nerve supplies the motor innervation to the thenar muscle. It is not a sensory branch. Superficial nerve, nerve near the flexor retinaculum, injured in superficial lacerations, immobilize the thumb and sensation. Immobilizes the thumb and the sensation is intact. What are we talking about? Recurrent branch of the median nerve. The recurrent branch of the median nerve. Is there any picture of that? Recurrent branch of the median nerve. Recurrent. Okay, this is the recurrent branch, right? So you can see, I guess this one is the recurrent branch. Let's Google it. Recurrent branch of median. So recurrent branch of the median nerve, also called as the thenar branch, innervates the intrinsic muscle of the thumb, abductor pollicis brevis, blah 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 blah. Where is it? So this is not a sensory branch. The recurrent branch of the median nerve is basically a branch that is going to supply the thenar muscle and the muscle of the thumb, basically. So I guess I was right. So this is the branch that is recurrent branch and going to the thumb area. Or in this picture you can see that it is $1 million nerve, the recurrent branch of the. Why is it $1 million nerve? I don't know. So the nerve, the recurrent branch is over here, I guess somewhere here. They have not. Yes, here you can see, this is a good picture. So here you can see that this is the recurrent branch. This recurrent branch is coming, is firstly the median nerve will go under the carpal tunnel, Then the recurrent branch will come over the thenar eminence to supply the thenar muscles. Okay, so this is a motor branch. While this branch, which is moving above the carpal tunnel, that is the palmar cutaneous branch of the median nerve. Remember the difference. So now let's come back to the PDF. Yep, over here. So we are done with the recurrent branch of the median nerve. Motor innervation of the thenar muscle. It does not have a sensory innervation. Superficial near the superficial nerve near the flexor retinaculum and injured in the superficial laceration immobilizes the thumb and sensation is intact. Now let's talk about ulnar nerve, that is CA to T1. The course of ulnar nerve, it enters the forearm after passing behind the medial epicondyle of the humerus. Within the forearm, it innervates the flexor carpi ulnaris and the medial portion of the flexor digitorum profundus. Okay, so the ulnar nerve basically is supplying the muscles which are not supplied by the median nerve in the flexor compartment. In the flexor compartment, most of the muscles are being supplied by the median nerve, and the muscles which are not supplied by the median nerve are these two, that is flexor carpi ulnaris and the medial portion or the ulnar half of the flexor carpi, flexor digitorum profundus. The nerve then enters the wrist between the hook of the hamate and the pisiform bone in a fibro-osseous tunnel that is called the Guyon's canal. So Guyon's canal is present over here, like it is a part of the flexor retinaculum. If it is the flexor retinaculum, on the ulnar end there is a small tunnel that is called as the Guyon's canal. Okay, so here it divides into superficial branch that provide a sensation over the medial 1.5 digits and hypothenar eminence in deep motor branch that supply most of the intrinsic muscle of the hand. So let's see the ulnar nerve over here. The ulnar nerve, musculocutaneous, then we have median nerve, and now we have the ulnar nerve. So ulnar nerve is supplying this area, like it is hypothenar eminence, the eminence below your pinky finger or little finger, and the medial 1.5 digits, like 1 digit complete in half digit over here, they are being supplied by the ulnar nerve, and they are the Guyon's canal over here, like over here from which it is passing. Then yep. So causes of injury: fracture of the medial epicondyle of the humerus, funny bone, proximal lesion, fractured hook of hamate, distal lesion in the fall of outstretched hand. Remember these two things, that either the lesion to the medial epicondyle or the hook of hamate that is ruptured or that is fractured during the person when the person is falling on the outstretched hand. So when these two type of fractures occur, the person can have this fracture that is called the ulnar fracture. And name some. So for the Arm University. So this was the last letter, and for the sum OME was specific for this. So O was for outstretched hand and ME for the medial epicondyle when we saw the dirty medicine video. Do listen to that video once again because that is wonderful video. Presentation: long loss of finger abduction and adduction, that is interosseous, ulnar claw on the digital extension, hand position at rest, and due to paralysis of the medial lumbricals. Presentation: loss of finger abduction and adduction, that are interosseous, ulnar claw on the digital extension. There will be ulnar claw deformity, hand position at rest, and due to paralysis of the medial lumbricals, radial deviation of the wrist upon flexion radial deviation of the wrist upon flexion, that is proximal lesion, and loss of wrist flexion of the medial fingers, loss of sensation over 1.5 finger including the hypothenar eminence. So if there is proximal lesion that is at the medial epicondylar level, there will be radial deviation. Okay, then ulnar paradox: the proximal lesion appears less severe. Proximal elbow lesion, ulnar claw may not be seen, ulnar digit paralyzed without clawing, and due to the loss of flexor digitorum profundus. Okay, that's a big thing, that if there is distal lesion, there will be ulnar claw hand like this. But if there is proximal lesion, so that appears less severe. Why so? Because ulnar claw may not be seen, and that is due to the loss of flexor digitorum profundus. Flexor digitorum profundus is lost, and that does not allow the claw hand to be formed. So that is the reason that the proximal lesions of the ulnar nerve are less severe. Okay, that is called as ulnar paradox. Now here you can see different, the cutaneous innervation of different nerves. Humerus fractures proximally to distally follow the arm, axillary, radius, and median. So the picture was like, okay. So firstly, if there is humeral fractures, the most proximal kind of humeral fracture at the surgical knife will damage the axillary nerve. Then at the mid shaft fracture, it will damage the radial nerve, and then at the supracondylar fracture, it can damage the median nerve, and then also a U, that is the mid-condylar fracture, medial epicondylar fracture, that will damage the ulnar nerve. So here they have given axillary nerve over there. Axillary nerve is over here. I guess the one twisting around the surgical neck of the humerus. Then you have the radial nerve. Okay, radial nerve is in the radial canal of the humerus. Then we have the musculocutaneous nerve, then median nerve, ulnar nerve. Median nerve is over here. It can damage it can be damaged as supracondylar fracture, then ulnar nerve, then radial and the recurrent branch of the median nerve, which supplies the thenar eminence. Then here you can see the cutaneous innervation. It is a bit confusing, but let's see it over here. Axillary nerve supplies the area over the deltoid. The radial nerve supplies the posterior part of the arm, forearm and the hand. So basically posterior part of the upper limb, and this small chunk in the anterior aspect as well. Then we have musculocutaneous nerve that supply the lateral aspect of the arm. Then we have like the medial antebrachial cutaneous nerve. Okay. Then the medial brachial cutaneous nerve. These two are the main branch. These two are direct branches on the brachial plexus. Medial brachial cutaneous nerve and the medial antebrachial cutaneous nerve. Both of these nerves are coming out of the medial medial cord, I guess. Yep. And then we have intercostal brachial nerve. I don't know from where it is coming. So remember these things. These are coming from the brachial plexus over here. From the medial cord, we have the medial pectoral nerve and no, the medial cutaneous nerve of arm and medial cutaneous nerve of forearm. These two branches are coming from the medial cords. So let's move to the okay in the hand. The ulnar supplies to the medial 1.5 fingers. The median supplies to the lateral or the radial half of the hand, 2-3.5 fingers, and then we have the radial nerve over here, medial nerve, radial nerve, and the ulnar nerve, dorsum of the hand. So they remember this kind of thing. Now let's talk about the long thoracic nerve injury. So long thoracic nerve is being supplied by long thoracic nerve is supplying the serratus anterior muscle. Causes of injury: axillary lymph node dissection, radical mastectomy as we have seen in the table before, lateral chest wall penetrating injury or the chest tube insertion. That is very important. That on lateral wall most commonly we insert the chest tube. If during the insertion of chest tube we somehow inadvertently damaged the long thoracic nerve, so the person can present to us with a winging scapula. Innervation: serratus anterior muscle. Origin: surface of the first 8 ribs. Insertion: the medial border of the scapula. Function: stabilizes and rotate the scapula upward. Abduction of the arm above the horizontal line. Presentation: scapular winging due to the inability of the serratus to hold the scapula against the thorax. Weakening in the abducting arm above the horizontal due to the impaired rotation of the scapula. Now, because scapula cannot rotate, like the rotatory movement of the scapula that was supposed to move the scapula like this in the over the thorax, so resultantly weakness in abducting the arm above the horizontal due to the impaired rotation of the scapula. Okay, moving forward. Actually, I did not explain that because we have talked about it so many times now. So let's move to the myotomes and reflexes of the upper limb. Myotome C4, that is over the shoulder, scapula, and this dermatome is responsible for scapular elevation. Then C5, shoulder abduction. C5, C6, elbow flexion and wrist extension. C7 is for elbow extension and wrist extension. C8 is for the wrist extension and finger flexion. T1 is finger abduction. Reflexes are C5, C6, bicep brachioradialis reflex. Bicep reflex is C5, C6, and tricep is C7, C8. So remember this part of the table first. Secondly, these are the myotomes. These are not dermatomes. So myotomes, these are the root values which are giving rise to different type of nerves. So if you want to remember this, do remember, but I just don't find a logic in remembering any of that. So C4 is scapular elevation. Okay, because levator scapulae maybe. I just forget about that. C5, C6. Okay, read this table and remember it if you want to. Then we have upper limb fractures, common humeral fractures. This one we have already studied. Let's read it now. So common humeral fracture, site of potential injury to the major nerves and arteries in the fracture of humerus. If there is damage to the surgical neck, so axillary nerve will be caught, posterior humeral circumflex artery will be caught. So these two things will be damaged. First one, axillary nerve. Along with that, posterior humeral circumflex artery will also be damaged. In the midshaft fractures, radial nerve is damaged along with the profunda brachii artery, deep brachial artery. Then supracondylar fracture causes the damage to the brachial artery along with the median nerve, and medial epicondylar fracture causes the damage to the ulnar nerve. Here we have seen these all the fractures. So fractures to the so let's see this picture once again, and then we'll be done by that. Fracture of surgical neck can damage the axillary nerve. Along with that, the circumflex humeral artery, posterior humeral circumflex artery. The midshaft hemorrhage can damage the radial nerve. Along with that, the profunda brachii artery. Then the supracondylar fracture over here, it can damage the brachial artery along with the median nerve, and the medial epicondylar hemorrhage fracture can cause the damage to the this ulnar nerve. Okay, so here are some arteries, and then let's move on. So supracondylar humeral fractures, They are common pediatric elbow fractures that often occur after the hyperflexion or hyperextension injuries, falling on the outstretched arm, maybe. These fractures carry a significant risk of the neurovascular compromise, particularly if the fracture is displaced. Anterolateral displacement causes radial nerve injury. We're talking about what? This is the kind of fracture we're talking about. If there is anterolateral displacement like this, so anterolateral damage to the radial nerve can be there. Okay. Then, if there is anteromedial displacement, so median nerve and the brachial artery can be damaged. If there is posterior displacement, ulnar nerve injury, usually hyperflexion injury, can be there. So listen, radius is on the lateral side. So if there is anterolateral displacement, there is a chance of damaging the radial nerve over here. Here you can see that whenever there is supracondylar fracture and the humerus was deviated anterolaterally, so radial nerve can be injured over here. If there is anteromedial displacement, so the median nerve can be injured because median nerve is passing over there. Median nerve is injured over here and the brachial artery is also injured, because we have seen that in the supracondylar fracture normally the median nerve is injured as over here. So the supracondylar fracture causes damage to the median nerve, and if it is anteromedial displacement particularly for the supracondylar fractures, so then brachial artery and the median nerve, both of them are injured together. Then if there is posterior displacement, then ulnar nerve injury is usually seen, usually hyperflexion injury. So due to hyperflexion, the ulnar nerve that is passing behind the medial epicondyle, that can be damaged. So remember these three type of lesions of the supracondylar fracture in the pediatric population. Then we have fracture of the distal radius. Now if the radius is displaced distally, so flexion fracture of the radius, that is called as the Smith fracture, and extension fracture of the radius is called as the Cooley's fracture. Okay, so transverse fracture within the distal, with the distal 2 centimeter of the radius. Transverse fracture within the distal 2 centimeter of the radius is called as okay. So transverse fracture within the distal 2 centimeter. So the distal attachment of the radius is on the disc joint. So at the distal 2 centimeter of the radius, the transverse fracture is called as the fracture of distal radius. Most common fracture of the forearm after 50 years of age, Smith fracture. The result from a fall or a blow on the dorsal aspect of the flexed wrist. So if you are falling on the dorsal aspect of the flexed wrist, it produces a ventral angulation of the wrist, okay, which means the radius will be moved upwards. Oh no, ventral angulation, pardon me. Ventral angulation, it produces a ventral angulation of the wrist, okay. The distal fragment of the radius is anterolaterally displaced. Anterolaterally displaced means anterolaterally displaced in ventral angulation of the hand. Okay, so let's check that. The ventral angulation. So the ventral angulation of hand looks something like this. Okay. So here you can see that the common distal radius fractures, the Cooley's fracture causes dorsal angulation, while the Smith fracture can cause ventral angulation. Okay. So if the person has acquired this form of the hand, that is ventral angulation, and here you can see the distal end of the radius has moved anterolaterally. Okay, so it has curved downwards, and an anterolateral deviation is seen. So just give me a second. Yeah. So anterolateral displaced, then Cooley's fracture results from the forced extension of the hand, usually as a result of trying to ease a ball or ease a fall by outstretched upper arm or outstretching the upper arm. Okay, distal fragment is displaced dorsally, that is called as dinner fork deformity or the Cooley's fracture. Often the ulnar styloid process is avulsed or broken off as well. So the ulnar styloid process and the distal fragment of the radius, both of them are fractured together in the Cooley's or the dinner fork deformity. Moving forward to the clavicle fracture. The clavicle is the most commonly fractured bone, and most clavicle fractures occur in the young children. After a clavicle fracture, the medial fragment is pulled superiorly and posteriorly. So the medial fragment over here, this medial fragment is pulled superiorly and medially, I guess. So superiorly and posteriorly by the sternocleidomastoid muscle. So you can see that the sternocleidomastoid muscle is attached to this fragment, and this is pulling it superiorly and posteriorly, while the lateral fragment is pulled inferiorly and anteriorly by the weight of arm and the pectoralis major, and the lateral fragment that moves downward and outwards, and basically the upper limb droops or upper limb falls down, and that upper limb is, when the patient comes to you, he will be holding the affected upper limb with his contralateral hand. So remember this thing. So these are some stabilizing movement of the clavicle. So sternocleidomastoid muscle and the trapezius muscle, they are holding the clavicle upwards, while the weight of the upper limb and the deltoid muscle, that is pulling the clavicle downwards. If there is a fracture, so there will be a very typical configuration of the upper limb. Here you can see that the middle part is moving upwards while the lateral part is moving downwards. Or here you can see, okay, that's a very atypical kind of fracture. But even in this fracture, there's not big movement over there, or displacement is not seen. But this is the characteristic clavicular fracture in which the medial 2/3 and the lateral 1/3 are broken down at the junction of these two halves. Then musculoskeletal system, we have shoulder dislocation. Anterior dislocation causes trauma. What's that? Venerable arm, abducted, externally rotated and extended. Okay, so we'll see the picture of that. Blocking a basketball shot, tackle while throwing a football. Complication, injury to the axillary nerve, loss of sensation of the deltoid plus weak abduction. So venerable arm, what's that? Venerable arm. Venerable. So venerable arm looks something like this. Short description. So venerable arm looks like this. This inferior dislocation. Where is it? I guess the venerable arm is when the shoulder is dislocated inferiorly and or posteriorly maybe. So what's venerable arm? The shoulder is inherently unstable joint due to the shallow glenoid articulating and small part of the humeral. I don't know whatever. I guess it's vulnerable arm, or maybe there's some grammatical mistakes, so forget about this. Vulnerable arm, abducted, externally rotated and extended arm. I guess it's about the vertebral strip injury or that injury which we saw over here. Yes, this one. The Urbs palsy. That was involving the C5, C6 nerve roots. I guess it was involving the axillary nerve as well. I think it is this one. I think it is this one. I'm not sure, but I think it is this one. Because the arm is adducted, extended and pronated, and here they are saying that the arm will be where it is. So they're saying that the arm will be abducted. Okay, no, it's not that. Arm will be abducted, externally rotated and extended. So it's not Erb's palsy, it is something else. So that is called the venerable arm. Then blocking a basketball shot and the tackle with a throwing football. So these things, the anterior dislocation can happen in these situations. Complications are injury to the axillary nerve, loss of sensation of the deltoid plus weak abduction. But if there's weak abduction, how the arm will be abducted? I don't know. I guess it is not a manifestation of the injury. It is a position of the injury in which the nerve can most commonly be damaged. So I guess it is not a symptom. And weak abduction will be there, and Erb's palsy can happen. So let's forget about that. Common pediatric fractures. First one is green stick fracture. What is green stick fracture? If you try to break the green stick from the green tree branch, it does not break into halves or completely. It remains attached. So the green stick fracture, bent bone from fracture. So the bone just gets bent. Fracture does not extend the width of the bone. Incomplete fracture, bone fails on tension side, compression side intact. Okay, compared to the torus fracture, and bone is bent like a green twig. Okay, then we have torus or buckle fracture. Axial force applied to the immature bone. The cortex buckles on compression side and fractures. Okay, the cortex buckles on the compression side and fractures like this one over here maybe. What's that? So the cortex buckles on the compression side and it fractures. While over here, the compression side is intact. In the green stick fracture, the compression side is intact, while in the torus or buckle fracture, the cortex buckles on the compression side and fractures. Metaphysis is most common side, and tension side, other side of the cortex remain intact. Okay, so what's that? Tension side. Okay, let's see a torus fracture. TORUS fracture. Torus fracture is a common injury in children. It is often caused by falling on the hand. The fracture causes one side of the bone to bend, but does not actually break through the entire bone. It is incomplete fracture. It is also incomplete fracture. Torus fracture, compression. Give me a second. Torus fracture, the compression and tension side. Compression tension side. The bending forces can cause the child to crease on the compression concave side of the bone, leaving the tension cortex convex, intact, but slightly bent. So this is about the cortex that I don't know. I have no idea about these two things. That So my concept on this is, suppose we are talking about green stick fracture right now. Suppose this is a bone which was like this, but it is a soft bone because it is a bone of a child. So there was some trauma from this side, and then the bone started compressing, and then bone started turning like this, right? Let's start over here. So the bone was turned like this. Now there are two sides. One side is the compression side where the bone is being compressed, or the concave side, and then other one is the tension side in which the bone is being elongated and stretched. That is the tension side. Okay, remember these two things. The compression side is the concave one, and the extension side is the convex one. The tension side is the convex one. So in the case of a green stick fracture, the compression side is intact, but there is rupture or failing from here. So the bone goes like this. Um, the bone is fractured from here, and it looks something like this, like a green stick. Because when you compress a green stick, when you bend a green stick, in that case, the compression side, or the side that is being curved, that remains intact, but the bone, or the green stick, that fails on the extended side. If you can see the green stick fracture over here, green stick fracture. Okay, green stick fracture. So here you can see that in this picture, that they have shown a green stick. So when try to break a green stick, the concave side, or the compression side, is intact, while the tension side on which it was being stretched, that is being torn. And same goes in this picture as well. Here you can see the bent ends. No, no. Here. Here you can see that when bone is bent over here, so the bent side, or the extended side, or the convex side, this one, that is being broken, while the concave side, or the compression side, is intact. So they are saying that bone failed on the tension side, that is the tension side, the side of extension, while the compression side is intact for the green stick fracture. Now if we talk about the torus fracture, it is opposite to that. That tension side, other side of the cortex remains intact. The tension side is intact, but the cortex buckles on the compression side and fracture. So what happens over here? It is also about immature bones. Let's suppose this is the bone, and this is also a bone that is being bent like this and this. So the cortex of the bone that buckles inside, that moves inside, and that causes a fracture on the compressed side, while this side is intact. Okay, here you can see that the extended side is intact and there is fracture somewhere inside. Okay, so over here the fracture is inside maybe. So the torus fracture, that is opposite to that of the green stick fracture. This is easy to understand. So understand the green stick fracture, and also remember that the torus or the buckle fracture is opposite to that of the green stick fracture. Now let's move forward. This is normal fracture. Then we have the green stick fracture, that is damage on the extension or the tension side. The torus fracture because of the buckling of the cortex inside on the compression side, that is causing the damage over here. And then we have the complete fracture look, which that looks something like that. Then we have wrist region. So there are these number of bones. So long to pinky, here comes the thumb. So long to pinky, here comes the thumb. Scaphoid, lunate, triquetrum, pisiform, hamate, capitate, trapezoid, and trapezium. These are 8 bones. 1, 2, 3, 4, 5, 6, 7, 8. Yeah, these are 8 bones, and this is a good mnemonic for that. So long to pinky, scaphoid, lunate, triquetrum, and pinky. These 4 are not pinky, that pisiform. So these 4 bones are present on the, I guess, the lower. So these are divided into 2 lines. The lower line is composed of where is that, scaphoid, okay, lunate, triquetrum, and the pisiform. These are on the lower line, and then other 4s are above that, which are hamate, capitate, trapezoid, trapezium. Hamate, capitate, trapezoid, and trapezium. Okay, so these 4 are above that, which is, here comes the thumb. Here comes the thumb is the upper line, while so long to pinky is the lower line. The trapezium is the most lateral and distal carpal bone and articulate with the first metacarpal. The thumb swings on the trapezium. The thumb swings on the trapezium, so it is the most lateral of the distal carpal bones and articulates with the first metacarpal. The capitate is the largest carpal bone and lies in the distal row at the center of the wrist. The capitate, where is capitate? The capitate is over here, so it is the distal. So there are 2 rows, that are the distal row, that is towards the hand, towards the fingers, and the proximal row, that is towards the arm or towards the forearm, you can say that. So these are 2 rows, and the capitate bone is the largest of all the what are these bones called? They are the largest of all the carpal bones, and that is present in the center of the distal row. Then we have scaphoid fracture. So where is scaphoid? Scaphoid is present somewhere over over here. Like this one is a scaphoid bone. This bone is a scaphoid bone. So the most commonly fractured carpal bone is the scaphoid. Causes of injury fall on the outstretched hand. So which nerve will be damaged? The ulnar nerve will be damaged. Axial loading on the hyperextended and the radially deviated wrist, commonly misdiagnosed at wrist sprain. Presentation should be suspected in any patient with a persistent wrist pain and tenderness in the anatomical snuff box. So if there is tenderness in the anatomical snuff box, you must suspect a scaphoid fracture. Complication: avascular necrosis and non-union due to the retrograde blood supply. Imaging: X-ray may take 1 to 2 weeks for X-ray to show the fracture. MRI most sensitive to the diagnosis within 24 hours. They have not talked about ulnar nerve damage over here. So let's forget about that. So in the scaphoid bone, because scaphoid bone is present lately, so ulnar nerve will not be damaged. So forget about that. Right now we are talking about the damage of the scaphoid bone alone. So in the scaphoid bone, there will be persistent wrist pain and the pain in the anatomical snuff box. The complication is avascular necrosis. If there is a picture of that, so here you can see there is a scaphoid bone is damaged, so there will be avascular necrosis. Why so? Because this is the scaphoid bone. If that is damaged, the blood supply is cut off, so the distal end will have avascular necrosis. So scaphoid avascular necrosis. Here you can see that this bone is damaged and this half is undergoing avascular necrosis because of the cut off of the blood supply, dorsal scaphoid branch and stuff like that. Okay, then leonate dislocation. It is identified on the X-ray of the hand as more medial of the two bones that articulate with the radius. Okay, the scaphoid is the other more lateral bone that articulates with the radius. The lateral X-ray shows lonely leonate sign. I guess this one is the lonely leonate sign. I don't know. Okay, so a fall on the outstretched hand can cause dislocation of leonate. So listen, a fall on the outstretched hand can cause a lot of things. It can damage scaphoid, it can damage the leonate along with the ulnar nerve damage. So if they're talking about some nerve deficit and then outstretched hand, so think about ulnar nerve. But if they're talking about some bone fracture and they're trying to bring you to the wrist bones or the carpal bones, so think about scaphoid or the leonate and just look for the lonely leonate sign or stuff like that if they're giving you an X-ray like that. They precipitate the acute carpal tunnel syndrome. Then there will be median nerve injury because if the leonate is displaced or dislocated, it will compress the carpal tunnel and the structure which are present inside the carpal tunnel. And we know that the median nerve is passing through the carpal tunnel, so that will be compressed. Injuries that cause the leonate dislocation also cause fracture of the scaphoid. So injuries that cause the leonate dislocation can also cause a fracture of scaphoid because they are present in very close vicinity to each other. So if there is damage or dislocation to one bone, that can also affect the other bone. So let's see this sign and then we'll close this session. Lonely leonate sign. Lonely leonate sign. Lonely leonate sign. So this is the lonely leonate sign. Okay, so leonate sign. The leonate bone, semi-leonate bone is the carpal bone, blah 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 blah. Lonely leonate sign. I guess the leonate sign will be present, alone somewhere. Lonely leonate sign. Okay, I just cannot get it. It looks something like this. That leonate bone is dislocated anteriorly and now it is present and it is compressing the, uh, you know, that carpal tunnel and stuff like that. So that is lonely leonate sign and it is very confusing. I just cannot get it. If you can get it, please explain it to me kindly. I just can't. So let's close the session over here, and from the next session we'll start with the metacarpal neck fractures inshallah. Until then, Allah Hafiz and Piman.